Thank you very much for the kind introduction. Thank you to those who are here in the room today, as well as to those of you who are participating via the webinar. I'm going to assume that most of you are broadly familiar with the objectives of the Meaningful Use program to advance the use of electronic health records and automated health information exchange. But my goal today is to give you a view of that program from the public health side of the fence. I'm going to take a fairly high-level view, and if you have very detailed questions about the specific meaningful use requirements, I'll provide information on how you can get that information. While we're waiting for that to come up, I'd like to start with a disclaimer, and I've often made this disclaimer. I've often heard others make this disclaimer that I am not an informatician. But this is my definition of informatics. We could all define it in our own way, but I view informatics as a discipline that spans the perspective and needs of the information users with that of...
I apologize. They just
Okay.
can't hear us online.
Oh, okay. Perhaps if I sit down, I'd be closer to the speaker. I'm going to change position to put my voice a little closer to the speaker. So to recap, I believe that informatics is a discipline that spans the perspective of the information user and the information technologist. And we're probably all living somewhere in this part of that span. So to paraphrase President Kennedy for the day, let's just say that we are all informaticians. I also like this definition of informatics that many of you have probably seen before by Chuck Friedman from the University of Michigan, that depicts the notion that the human brain plus the computer is greater than the human brain alone. I'd like to doctor that slide to emphasize that the human brain plus the computer is greater than the computer alone. And I'd like to make this point because I believe it's important to emphasize that there's a critically important role for the human brain. Sometimes in our zeal and enthusiasm for technology, we tend to forget that. But it also means that in order to achieve the promised potential of any form of information automation, particularly in the arena of health, that we need to think about the human capacity to take advantage of this opportunity. In the overview of my presentation, I'd like to talk about the role and interest of public health in the Meaningful Use program. And there's really two parts to this. The first is the specific reporting requirements that are in Meaningful Use for healthcare providers to report certain information to state or local health departments. That information and the requirements have varied somewhat over stages 1 and 2 of Meaningful Use. There's also some shift in terms of which measures are so-called core or required measures and which are menu options. And there's some variation in the requirements for eligible providers and eligible hospitals. I'm not going to dwell on these distinctions today, but I can refer you to that. I'd also like to emphasize that the interest of public health in the Meaningful Use program goes well beyond the specific public health reporting measures, and I'll return to that towards the end. I'm going to walk you through the public health view of the 3 reporting measures that started in stage 1 of Meaningful Use, but I'm going to dwell the most on the 3rd of syndromic surveillance and talk somewhat about a program at CDC called the BioSense program, which you can view either as a cautionary tale or a path to the future in terms of the application of information technology to public health practice. And then I'll close by reflecting briefly on the question, what will it take to achieve the population health objectives of Meaningful Use? Just to recap, I'm sure that you're all familiar with this, the 4 objectives of the Meaningful Use program, which aims to incentivize the use of electronic health record technologies, are first, better clinical outcomes, improved population health outcomes, which I've bolded for the sake of this presentation, and which I will focus on today, as well as increased transparency and efficiency, empowering individuals, as well as the capacity to have more robust research data for health services or health systems research. And the three stages of meaningful use have been variously described. This is one illustration from the Office of the Office of the Coordinator for Health Information Technology, or ONC, at HHS, with the first phase focusing on the adoption of the EHR, the second phase focusing on exchanging information. We're now in stage 2 of meaningful use, and the third stage, which is slated to begin in 2016, although that might be postponed a year, which will focus on improving outcomes. And I really want to, particularly at the close of my talk, think ahead to that improving outcomes stage. I'd also like to emphasize that there's a harmony or a resonance between the objectives of the Meaningful Use program and the objectives of the Affordable Care Act, which include the triple aim of improving the individual experience of health care, improving the health of populations, again bolded because that's my emphasis today, and reducing healthcare expenditures. So who is the population that we're talking about? And this is a term that means different things to different people. From the perspective of the healthcare provider, that population may be the group of people under your care. Or if you are an insurer or a health plan, the population are the people who are the enrollees in your plan. From the perspective of public health agencies, the population is the people who live or work or visit the political jurisdiction that is under your responsibility. That may include the city, if you're a city health department, a county, the state, the national level, or the multinational or even global level. One of the common features about thinking of a population at each of these levels is that the population can also be considered your denominator. And I like to define epidemiology as the people, or epidemiologists as people who have people in their numerator and denominators. And so the push towards improving the quality of health care, the push towards encouraging clinicians and health plans to think about the populations of patients under their care, then encourages us to think about the percentage of people in those populations who are receiving the recommended care, the percentage who are achieving the various quality or performance measures. And from the epidemiologist's perspective, it enables, we think about the rates of disease or disease prevalence. But the notion of a population is that we're thinking about our denominator and what proportion of those denominators have outcomes that we either desire or seek to avert. As I mentioned, I'm going to focus on the role of health information technology from the public health perspective. And this is not something that just started with meaningful use, but this is something that's been developing for decades, beginning at least in the course of my career in the early 1980s, when we first started seeing microcomputers on the desks of epidemiologists and at CDC and in state and local health departments. And over that time, there's obviously been a tremendous evolution in public health information technology that has occurred in parallel with the evolution in healthcare IT. What the Meaningful Use program has done, in essence, is put the pedal to the metal. That it's been disruptive in the current use of that word in both a positive and potentially threatening way that creates opportunities as well as challenges for public health and healthcare. The critical questions then are, will the very rapid changes or the acceleration in long-term trends that are being prompted by the Meaningful Use program be successfully absorbed, and will meaningful use be meaningful? And then how will we know? I'd also like to emphasize that when we think about health information technology from the public health perspective and our interface with the healthcare system, we're thinking about a lot more than just the electronic health record or health information exchanges. For many years, public health agencies have worked with the healthcare world to access and use administrative data, registration systems, billing and claim systems, hospital discharge databases and ED visit databases, vital event databases, birth certificates, death registration, of course EHRs, laboratory information systems. We also are increasingly concerned now with health information exchange, both as a noun, as a verb, the act of exchanging health information, but also the establishment of entities that facilitate the exchange of health information among providers within a geographic region. Although I'm not going to talk about it today, we also depend very heavily on surveys and the emerging world and opportunities afforded by the so-called field of big data. I like to quote, perhaps an overused quote, from a French philosopher from the 1800s: the more things change, the more they stay the same. And I think what's changing is what's changing are the technologies, but what stays the same is the importance of the relationship between the worlds of healthcare and public health. From the public health perspective, the healthcare world is the source of most, certainly not all, but most of the information that we use to track the health of populations. The population is our patient, and that process is called population or public health surveillance. And most of that data comes from information that arises from healthcare transactions or interactions. In addition, many of the recommendations that public health agencies make, whether that's at the federal level or recommendations that come from your state or local health department, are developed in collaboration with healthcare partners and are effected or put into practice through healthcare interactions. Clearly, health information automation is reshaping this enterprise, but it's also shaped by the very long-standing roles and relationships within and across the healthcare world. We also often describe the process of public health surveillance or population health monitoring as a cycle, which begins and ends with our constituents, typically the world of healthcare and the broader public. Public health agencies collect information from healthcare providers and the public. We may actively collect that directly. We may tap into existing databases or otherwise harvest various data sources. And increasingly, this entire cycle is being automated. So the process of collection, data management, updating the databases as new data come in, analyzing those data, looking for unusual trends, whether those are trends that are happening over a period of years or whether those are trends that are happening overnight to detect disease outbreaks or to detect evolving trends in public health. We also use those data to monitor the status of our patient. Are there important health disparities? Are there groups within the population that are at higher risk for disease or given disease for adverse outcomes? The technologies are also helping to visualize those findings, to find that needle in the haystack. And I've put interpret and assign meaning to those data in a different color to emphasize that this is where the machines haven't completely taken over. This is where the human brain still plays a very critical role, although automation tools can help that process. And then equally important is the dissemination and feedback of that data that's used not just by public health, but it also informs healthcare practice and policies. It also has a very important role in shaping what we do in public health, how we set priorities, how we target our programs, how we define our policies. Turning now to the public health reporting requirements or options in the Meaningful Use program. Each of them has the following structure, and this is a direct quote from a couple of reports from CMS. The objective is to demonstrate the capability to submit electronic data, and the X, we'll come back to that, what that X represents, to public health agencies, and actual submission, except where prohibited, and in accordance with applicable law and practice. Now that latter phrase, except where prohibited, was put in to allow for situations where public health may not specifically mandate certain requirements or certain reporting, but authorizes it. But basically, it's to support the public health practice of collecting health information. In stage 1, it's defined as, where the requirement is, demonstrate that you've performed at least one test of the use of a certified electronic health record technology's capacity to provide those data to public health agencies, and then follow-up submission if the test is successful. So it's a pretty low bar that you just have to demonstrate that you've tested, and if you pass the test, that you can then take the next step to begin submitting data. Although there's a qualifier here. If that public health entity, or to which that public health entity has the capacity to receive that information. So if public health says, we're just not ready, you get a pass. In the second stage, it ups the ante, and it requires successful ongoing submission of electronic data for whatever it is we're talking about from the certified EHR technology to the public health agency for the entire reporting period. And again, the references that are in the invisible print at the bottom of this slide, or also repeated at the last slide, can provide more specifics on this. The onus, though, is on the public health agency to publicize which of the reporting measures they're accepting and the information on how to establish that handshake. So what are these reporting requirements or options? So stages 1 and 2, there are 3. The first is to report laboratory results for reportable diseases. And I'm going to return in depth to more to each of these. The second is to report immunization services to an immunization registry. Right now, that's just a one-way report. Downstream, it'll be the capacity to receive information back into the EHR in the future from the immunization registry, or immunization information system as it's now called. Or the third is to report syndromic surveillance data. Stage 2, as reporting from cancer registries. In considering planning for stage 3, ONC's Health IT Policy Committee considered dropping all of the public health requirements. This consideration was not a reflection of any particular concern or a sense that these were no longer important, but rather a sense that, well, we've had these requirements for several years, they should fly now without it. Public health departments vigorously responded, and as well as organizations that represented them, that said, no, these need to remain in the ONC and CMS meaningful use requirements, at least into stage 3, to assure that those are successfully established for the long term. There was also a proposal to add the full picture of case reporting. Right now, the case reporting requirement is just for the laboratory result, but that was not accepted, and I'll return to that a little bit later. The Meaningful Use Program presents both challenges and opportunities for public health and the information process that it supports. Ideally, the automation of these information exchanges that no longer depend on somebody filling out a report form or somebody sitting down at a terminal entering data, but that they can occur automatically, therefore reducing the time and effort on the part of healthcare providers to submit the required reporting, and diminishing the burden on public health staff to receive and manage that information. Ideally, it would improve the timeliness, the completeness, and the quality of those data, and it would free up the time of both public health and healthcare providers, but particularly from the public health perspective, to use that data and to act on what it shows. The challenges for public health, I've heard it said this is the best of times and the worst of times. It's a tremendous opportunity for public health coming at what might be the worst possible time because of the recession and budget cuts and staff cuts that many state and local health departments have faced. Beyond that, public health agencies have been somewhat consumed by the need to develop standards, the new procedures, documentation of provider incentives. The processes of establishing meaningful use have overwhelmed many health departments in a way that haven't let us really step back to think about, are we really going to be able to take full advantage of this new opportunity? And while the Meaningful Use program was a very substantial investment of nearly $30 billion, most of that money has gone into the incentives, and actually very little of it came to public health departments. So ironically, while the architects of the program built into it public health objectives, it did not include sufficient funding for public health departments to really be a full partner in the enterprise. Many health departments have limited informatics and IT capacity that's been aggravated by budgetary constraints. In addition, they've operated a myriad of legacy systems that need to be adapted and revised to meet current standards, and public health isn't in the driver's seat. If you look at every dollar that's spent in this country for health, governmental public health accounts for about 3 cents on the dollar. So obviously this is being driven by the healthcare industry, and most appropriately is there to meet the needs of healthcare. Public health has to be at the table, but it struggles to be at that table effectively sometimes. So turning now to these three sets of reporting measures. The first is what's probably the oldest form of public health surveillance that dates back into the 1880s, the reporting of certain diseases that's mandated by law to public health authorities. This reporting is based on the authority of states to require that clinicians, hospitals, and laboratories reports at the individual level certain cases of specified diseases. Every state has its own list of these diseases that the doctors, hospitals, and labs are required to report. Historically, the emphasis for this has been on infectious or communicable diseases, although many states use that authority to require reporting of other conditions. That is closely linked to the role of public health at the local level to respond to those cases of disease and to intervene as part of prevention and control programs. So those data get used both at the individual as well as in the aggregate level. The Council of State and Territorial Epidemiologists works with CDC to designate a list of about 70 or so of those diseases that get shared every week with CDC, and you'll see that reported in the morbidity and mortality weekly report. The completeness and timeliness of this reporting varies substantially by disease and across states. Even though it's required by law, just requiring it by law doesn't mean that it happens. And oftentimes it's those programs that have the most money and the most resources to take an active approach to outreach and engaging providers to assure complete reporting, get more complete reporting. There's also been a movement for a number of years to support laboratory-based reporting. There are many fewer large clinical laboratories in a given area than there are doctors or hospitals. So if you could reach out to the laboratories to require that they report at the very least the positive laboratory result, that's a very important trigger to at least initiate a case report and assure more complete and timely reporting. And work to establish this has been going on since the late 1990s when CDC worked with its partners, state and local health departments and the clinical world to develop a set of standards to support laboratory-based reporting. And as of last year, 54 out of 57 grantees, you'll see me use the word grantees, different programs at CDC fund different grantees. It's typically all the states and the District of Columbia, and then some programs support a variable number of large cities or large counties. But as of last year, a very substantial percentage of health departments had initiated some form of electronic laboratory reporting. The traditional relationships are that clinicians and laboratories are exchanging information with one another, that they then share the information on reportable conditions with either the state or local health departments. There's an exchange of information between the state or local health department, and typically the state, but sometimes the local entity then shares that information with CDC. Early on, much of the focus on automating this process focused on the step between health departments and CDC. Now, investments in automation are focusing on the stage between the world of clinical practice and the local health departments. And again, this has been a long-term evolution. Before the advent of microcomputers, this reporting happened by mail, by telephone, by facsimile. When the microcomputer revolution occurred, different CDC programs started developing their own programs. They'd send out the diskettes to health departments, and then we had the problem of every program with its different software, so that it was work done to standardize that. Then we saw the evolution of web-based utilities. Now we're looking at the potential for using cloud-based services to support this. Historically, this reporting process has been a push process where information is sent out from providers to health departments. There's also been, at least in those areas where public hospitals are in the same organizational entity as the health department, some precedent for health departments being able to reach into electronic health record systems to pull out information, and now there's more work being developed to develop that pull capacity on a developmental basis. But there's tremendous variability among states in their IT and informatics capacity. Some of them use different CDC-provided software programs. One of the consequences of that is there's been a profusion of standalone systems developed by different CDC programs that are in place. Other health departments have taken a grow-your-own approach and have done their own in-house development. Some have used a mix of in-house development and CDC or off-the-shelf commercial or open source modules for different elements of the surveillance process, and others depend on vendor services using either bare bones options or the full bells and whistles options from different information vendors. And thinking about the question of should the stage 3 meaningful use expand to include the full case reporting, so not just the laboratory report, but asking your EHR to report all the other information that goes with a case report, the demographic information, some of the clinical information, other laboratory values that might go into affirming the case. That question was addressed by the policy committee that is considering stage 3 of meaningful use. And the criteria that they used was, in thinking about adding new reporting requirements to stage 3, is this something that fills an important need? Is this important? Do we care about this? Is this meeting a need? But the second and most, probably more critical issue, or the breaking issue, is are we ready? Are the data standards to do this sufficiently mature? Is there evidence that it's feasible? And somewhat ironically, even though case reporting is the oldest public health reporting enterprise, it was felt that there's still too much variability among states, that the data standards really are not ready, and to a certain extent we're the victim of our history, that there's so many entrenched approaches that the capacity to do this in a standardized way, as well as developing the mechanics of it, is really not ready. That contrasts with the decision to add cancer registry reporting in stage 2, which took advantage of the work that cancer registry organizations have done over the last 20 or so years to really develop and standardize cancer registry procedures, which enabled cancer registries to be added, reporting to cancer registries to be added in stage 2. So this is a slide from my informatics friends that looks at some of the work that's happening now to try to develop the automation of case reporting. And I'm not going to walk through this in detail, but if you envision the network of public health providers, and this is one approach that's being piloted now in a certain locality, that information might be extracted into a clinical data warehouse, that there's a decision support tool that is able to access various resources from public health, a reporting form or reportable conditions mapping service that helps decide, is this clinical event indeed a case that needs to be reported, that pulls in the various vocabulary terms and then reports to public health. And every line and arrow and box and circle on this is an area of active development, and many pieces of this are in place for the routine transactions that are now occurring. But the full automation, particularly in terms of being able to tap into an EHR and extract that information and send it, is yet to be developed. Turning to immunization registries, and the sequence here is from the more to less mature. Immunization registries have been in the works since the early 1990s. In 1993, CDC first issued grants to its immunization grantees to start planning the development of information registries and developing standards. By 2012, all but one state and a few localities had established an information system, as the registries are now called. This has given the information registry enterprise time to develop standards and procedures, yet interoperability from one information registry to another is not yet fully achieved. So while your patient's information may be located within one registry, the capacity to transmit that information to a registry in another locality, if that person moves, is not fully in place. This is a concern not only to the information registries, but it's also a very big concern to the EHR vendors who are trying to develop products that meet the reporting requirements, and that variability is a challenge for them. With notifiable diseases, while every state has legal mandates for that, the picture is somewhat different for reporting to the information registries, with the different colors here, the darkest being states that mandate reporting of all immunization services regardless of age in the darkest color, and then progressing down to those that require reporting of childhood or young adult immunizations, those that require reporting for just young children, or those that don't have a reporting mandate but do authorize the reporting, and then it hashes the few that don't have a registry. Syndromic surveillance is, in many respects, the new kid on the block. The process is relatively widespread, but not nearly as mature. Unlike most other surveillance activities which aim to collect information on certain events, syndromic surveillance is somewhat different. The premise of syndromic surveillance is that it aims to collect a little bit of information about everybody that steps across the threshold of certain participating facilities, particularly hospital emergency departments. So if you think as the emergency department as a place where a public health crisis is likely to initially become manifest, the aim of this type of reporting is to collect a little bit of information that allows you to develop a very quick snapshot of trends within the community. It's based on parsing text of the chief complaint, or it might use a pick list for the chief complaint, or ICD-coded diagnoses when the person walks out of the ED, but often that's before definitive diagnosis is established. So it's a very non-specific approach. It's painting with a very broad brush, but that lack of specificity is offset by its timeliness. You can know broadly what's going on in your community yesterday. This investment was really prompted by concerns about bioterrorism after the events of 2001. And both CDC and the Department of Homeland Security provided funding to states and cities. Unlike the traditional trajectory where surveillance systems have been developed first at the state level and then at city levels, much of the leadership for this form of surveillance came from cities, which were really, in many respects, on the front line of concerns about the threat of bioterrorism. And historically, there was variable state engagement, although that's now changed. By 2007, 43 of 52 areas that responded to a CDC survey, or a CDC-funded survey rather, were conducting some form of syndromic surveillance. The most typical form was based in emergency departments, but typically that wasn't statewide. Often that was with a relatively limited number of hospitals that had volunteered or agreed to participate in the system, and that were willing to share that information. Absent the large-scale bioterrorist attacks that were the concern that prompted much of this investment, this capacity has had a variety of uses for monitoring seasonal illness, the impact of disasters, chronic diseases, injuries, or for tracking what's going on around a large event. If you're the host of the Super Bowl or one of the large every 4-year political conventions, you've got a lot of people coming into your community. It's a way of knowing, are we seeing any problems that might need attention. This is just one example of the use of syndromic surveillance from Philadelphia, which tracks ED visits in blue and pediatric visits in red. The lighter line is the historical trends over 3 years. The darker line is the trends for this flu season, and we can see that this flu season has been less severe. This is influenza-like illness just based on what you can parse out of the chief complaint. It's non-specific, but when you couple that with other more specific laboratory-based monitoring systems and other systems, it helps to define part of the picture of the flu season. In hindsight, there's been some debate about whether meaningful use was ready to be a meaningful use reporting measure. It was selected because of the precedent for automation. It's a highly automated, everything about this is automated. It lacked the standards. The legal status is variable. Most states do it under the general reporting authority to collect this type of data. Very few states actually require that. So the legal infrastructure is less well developed. And states have varied in their assessment of whether they really need this expansion that the meaningful use requirement would enable. I want to talk very quickly about the CDC BioSense program. This was an extraordinarily ambitious effort that CDC launched in 2004 to create, in effect, a national syndromic surveillance system. It was a departure from CDC's traditional way of doing business. It aimed to support in both national level syndromic monitoring as well as local capacity. It initially drew upon data from the Department of Defense, which operates clinics around the country, the VA, and a large commercial laboratory network. But CDC took a rather unusual step in 2005 and 2006 and modified that to initiate a very ambitious effort to collect extensive, deep clinical information from a large number of hospitals that would report that information directly to CDC. This was a departure from the traditional pathway of information flowing through health departments, and the goal was to enlist over 3,500 hospitals in 40 large cities. This is a list of the set of data that was obtained. So most syndromic systems collected maybe 10 or 12 variables. This is a very deep, extensive set of data that they aim to collect. Unfortunately, the BioSense program fell short of its aspirations. Its recruiting targets were never met. Eventually, about 400 or 500 hospitals were enrolled. It proved to be extraordinarily complex and cumbersome. It was difficult to take full advantage of the avalanche of data that it collected. It was very highly dependent on the involvement of multiple contractors, each involved at a different stage in the process, which added further complexity. It turned out the system was relatively underused by many local health departments, many of whom were upset by being bypassed in the process, and many of whom were frustrated when data analysts in Atlanta would find something but lacked insight into the local context. and detected anomalies that then got reported back to health departments. It was subject to multiple GAO investigations in terms of how much money it was spending and whether that was used wisely, which eventually led CDC to abandon efforts to recruit additional hospitals and to plug in existing health department systems. But by that time, the relationship with CDC around this effort had been somewhat soured, and fewer than 10 health departments signed on. The low point, and if you're working for the federal government, this is not the kind of headline you want to see in a trade journal. The headline was BioSense or Biononsense, years of development and hundreds of $millions later, what has CDC's syndromic surveillance program accomplished? And a leading and very respected authority testified before Congress in 2006 that among local health departments, the program has another name, Biononsense. That was, I think, probably the low point in the history of that entity. So in 2010, a substantial investment was made to turn the program upside down and inside out. It was based on lessons learned, involved the overhaul of IT and contracting procedures, very active engagement of partners, funding many of the organizations that represent health departments. It was based on a model of the data going from hospitals to the state, instead of to CDC, to the Association of State and Territorial Health Officials, which acted as the national aggregating entity under contract from CDC. And even though the pathway of the electron flow might go differently, that was the pathway of how the information was to be used. It also invested heavily in developing the meaningful use standards and, in essence, a catcher's mitt for meaningful use reporting. Another element of the redesign was the use of internet cloud platform as a service technology to receive and manage the data, to give each state their own space on the cloud, a locker, so to speak, to use for their services and systems. It also afforded opportunities to share information from one health department to another, or with CDC. It's based on a proprietary cloud service that's managed by ASTO under funding with CDC. It meets federal security standards. It's vastly less expensive by an order of magnitude than server-based systems for managing this enterprise, and it enables the catcher's mitt function so that a health department can say, I don't really want to develop the capacity to absorb expanded syndromic surveillance reporting. I'll use the BioSense catcher's mitt to do that for me. It's still a work in progress. Well, many states have signed on. The data sharing arrangements have yet to be fully mature in a way that enables the system to be used optimally. There's been some onboarding bottlenecks. Analytic systems are under development. But it's a dramatic change, and a lot of very constructive work is now underway to realize that potential. The utility goes well beyond BioSense. CDC's experience in a sense, cutting its teeth on the automation of BioSense really positioned it to be an effective player in the meaningful use enterprise, and there are now discussions about using this notion of the cloud as a platform as a service, and shared governance concepts for other systems. As of this year, this is a map that shows the percentage of eligible hospitals participating in the Meaningful Use program that have selected at least one public health reporting measure. The options are different from state to state. If not, some states aren't accepting all three. So this is also a reflection not just of hospitals' capacity, but also of states' capacity. And basically, the darker the color, the greater the percentage of hospitals that have selected and are demonstrating the exchange of one of the public health measures. Most of that, the most frequently used one is immunization reporting, with much lower levels of electronic laboratory result reporting or syndromic surveillance reporting. I'm showing this slide as I transition to the public health interest beyond meaningful use. This is a slide from CDC that articulates the CDC director, Dr. Thomas Friedman's priorities for the agency in terms of improving health security, which depends on accurate systems to monitor the health of populations, better preventing the leading causes of death, most of which now are chronic conditions that are also the focus of the Affordable Care Act, and much effort to improve the coordination of care and strengthening the public healthcare interface. Many of the mandates or requirements in the Meaningful Use program that clinicians or hospitals need to demonstrate touch on areas of deep interest to public health: recording smoking status, implementing decision support tools, monitoring clinical quality of care measures, generating lists of patients for quality improvement. All of these are areas where there's opportunity to improve the use of preventive services, to improve decision support in the use of screening activities or interventions that are of shared concern to public health and the healthcare world. And lastly, the question arises, will the successes of early EHR adopters be replicated through an economic stimulus program that incentivizes via the Medicare and Medicaid programs EHR adoptions by virtually all hospitals and medical practices? At a place like CHOP, which has been in the vanguard of health information technology and other large centers like this, there's clearly evidence that there's been a long history of evolution of the use of this technology and evidence of the multiple benefits that it affords both for individual patient care and the quality of care. The question is, will that experience be translated and seen by other providers who are not in a setting like this? And will the population health objectives be fulfilled? This slide shows a doctor trying to decide, do I buy the inexpensive system or the expensive system? The kind of headlines that we're seeing, that the potential is not yet being fulfilled, or a resource that perhaps some doctors are using to make this step. The population piece of this will be assured, or I would say will not be assured, if providers don't understand why they're reporting to public health, if it's just perceived as a ticket punch to get the incentive payment, if public health really isn't ready to receive that data, or if they can receive it, if they're not really ready to use it, if they can't show the value of getting that information, and if they can't feed it back to the rest of the world in a way that demonstrates the utility and the insights that are gained from it. It will be successful if health departments really have the capacity to make effective use of that expansion of the information that's available to them, that they can use that information to get to the stage 3 objective of improving health outcomes. That better information indeed leads to better information and guidance that public health can provide to clinicians for those conditions of shared concern to healthcare and public health, that we can also use that to develop and put into effect more effective public health programs. Right now, evaluations that have really been about the process measures of establishing connections, attestation of information exchange, the number of enrollees, et cetera. But I think it's going to be incredibly important to build the partnerships that we need between the academic world and the clinical world and the public health world to begin to develop the evaluation frameworks and the research protocols and the evaluation protocols to measure, how will we know that this is meaningful, that the health outcomes are being improved, and what can we do if that's not happening to make sure that it does. I've gone a few minutes over time, I apologize, but I'll stop now and first take questions from the audience. This is a list of resources from CMS, ONC, and CEC. For those of you that would like to know what the requirements are, options for your locality, plug into Google or your favorite search engine the name of your state, the health department, the the word health department and meaningful use, and you should get to the information that you need to know how to connect with the public health aspect of the meaningful use program.
Great, thank you.